Good morning, everybody, and thank you very much for inviting me to be part of your conference today. It's wonderful to see two different professional groups working together, something that we need to do as part of our professional career. Um, and thank you very much to Claire and Sally for inviting me. I'm sorry I can't do this recording live. Um, Thursdays happens to be my grandma day, where I get to look after my 40-month-old granddaughter, and trying to present with her on my knee might have been quite a challenge. So, what are today's aims and objectives? Because in academia, we often have to have aims and objectives. Um, I want to look at why breastfeeding is important and how it is possible to support lactation even when there's chronic medical conditions. Breastfeeding and medication does go together, and that's what I've been saying for a very long time now. So, in doing so, we're going to look at why breastfeeding is important, how it works, and how, in trying to deal with medications, we can impact supplies. Um, but most importantly, how we can support maternal choices and facilitate empowerment of the families to look at what medications the mother might need and how to go forward. And largely, I'm going to do this by some case studies. So, first of all, excuse me, who am I and why am I presenting this to you? So, I'm a pharmacist. I was born over a boot shop more years ago than I'm going to admit. Um, and I kind of got used to the fact that we opened a pharmacy at weekends if people needed prescriptions, and that's why we had a flat over the top of it. In due course, I had three daughters, and I found breastfeeding something I became quite passionate about. And one of the reasons for that was because I have a condition called Crohn's disease, and I found that I was healthiest when I was pregnant or breastfeeding. And I started to wonder why this was. So I went away and trained as a breastfeeding counsellor, and somebody said, well, why don't you put the two bits together, the pharmacy and the breastfeeding support, and update some information. We've got two A4 sheets of information, and we'd like a few updates. So I went away and worked in a community pharmacy for 2 weeks. And it happened to be a homeopathic pharmacy. Nobody wanted to speak to me, and I knew nothing whatsoever about homeopathy. So I spent the time putting the first information sheets together, and that was in 1985. And I produced 30 A4 sheets, which NCT sent out to professionals all across the country with my home telephone number on, and I had very kindly offered to answer any questions that professionals might have. And can you imagine the chaos that ensued? My phone never stopped ringing. So I became more and more passionate, decided I wanted to write a book, but I didn't really know how, and I wanted to understand a little bit more about breastfeeding and medication and academia. So I went away and did a PhD on the community pharmacy role of supporting mothers requiring medication during lactation. I always remember the dean stumbling over that at my PhD graduation. But I actually graduated on the same day as my eldest daughter got a first in biomedical sciences. So there's not many people who can have a graduation photograph with their children. I carried on being a community pharmacist until 2002, and then went to work in GP practices and became an independent pharmacist prescriber. But about 11 years ago, I decided that wasn't really where my heart laid, and I wanted to stop doing all of this and write books and develop a website. But imagine my surprise one day when I got a phone call from the Department of Culture, Media and Sport saying, what's this you do about drugs and breast milk for the Breastfeeding Network? We understand you write some fact sheets and you provide voluntary information. I told them what I did, and I received a Points of Light award from the then Prime Minister Theresa May. But even more surprising was that the following December, I was nominated for a MBE for Services to Mothers and Babies, which I received from the Queen in 2019 at Windsor Castle, the pinnacle of my career. I never thought that was possible because I was just a normal person. I'm just a mum with 3 children, 7 grandchildren, but a bit of a passion. And luckily, the ability to have been able to spend that time providing information. That time I was working for the Breastfeeding Network, and I wrote lots of fact sheets on there, which are still on the websites to be accessed. And though at that time we had telephone and social media service and an email service, we had given up on the telephone line because there were only 2 of us to answer, and it just became overwhelming. But when I left, I believe that I was answering 10,000 queries a year from mothers and professionals about drugs in breast milk. The service has now been taken over by a group of 20 wonderful pharmacists who are able to answer on a rotational basis, and I've realised quite how crazy my life was at that time. Now I've retired and just work on my own website and trying to continue educating people like you, undergraduates, postgraduates, trying to get onto committees to work with them on altering guidelines to facilitate breastfeeding and medication. But I'm still just a mum and a grandma. So back in 2016, there was a series of articles in the Lancet about how important breastfeeding is, not just for a health basis, but an economic basis. And Hansen said, if it didn't already exist, the person who invented breastfeeding would get a dual Nobel Prize for medicine and economics. We've talked for a lot about breast is best. That actually was a term that was initiated by the formula companies, not by breastfeeding advocates. Breastfeeding advocates do not push people into doing what they don't want to do. We are all trained to counsel, support, and empower women. But it does have this massive benefit, not just for the health today, but in the future. So, for instance, children who are breastfed are less likely to be obese in future. There was a low in breastfeeding in about 1980, which was when I had my eldest daughter, when virtually nobody breastfed, and we lost a lot of the skills around enabling pain-free, effective breastfeeding. So breastfeeding protects babies against a whole host of conditions that formula can never manage to do, however much the formula companies say that theirs is just as good. And while we're on that topic, it doesn't matter what formula a mother uses. The cheapest product from Aldi or Lidl is just as good as the most expensive brand on the shelf. And the current economics where women are looking to food banks to provide formula milk or are stealing it in some cases is absolutely wrong, because the formula manufacturers are just spending all their money on advertising. There was a BBC report last week where a mother said, I need to give my baby the best, so I have to give the most expensive. Sadly, they wouldn't be in this situation if we'd put more funding into supporting the breastfeeding at the beginning. And we would be protecting the children against all of these conditions, which would affect them not now, not next year, but the next 10 years, 20 years, 50 years. But magically, it also protects mothers against ovarian breast cancer and breast cancer. I'm also involved with a group called Mummy Star, which supports mummies who are, or families where the mummy is diagnosed with cancer, either during pregnancy or in the first 12 months of after delivery. And these mums have to stop breastfeeding or only be able to breastfeed for a small window so that they can have chemotherapy. It stops the resumption of the menstrual cycle. And on social media groups, it's often see people saying, I haven't had a period back for 2.5 years now. Is that normal? Yes, celebrate it. Look at all the iron you haven't lost in that monthly bleed. Look at all the money you've saved. But there is also a paper that it protects mothers from a lifetime risk of cardiovascular disease. What more could we want from something that's being produced by the body free of charge? But we also need to be aware that chronic conditions are impacting more and more people. Apparently 10 to 20% of the population now have a chronic disease. And many of these are autoimmune diseases which can in part be linked with being formula fed as a baby, because formula milk is made of cow's milk protein, and that's a foreign protein. And as it passes through the gut walls in the very early days after birth, it can set up strange reactions that alter the way the baby's gut develops for the future. And it wasn't until I started writing my last book about chronic conditions that I discovered that women are far more likely to develop autoimmune conditions than men. Why? I haven't been able to find a rationale. It's not just we go to the doctor and we get diagnosed. We actually do have more of these conditions. But then this becomes a barrier when we become pregnant or are breastfeeding. Back when I started, most people with chronic medical conditions were probably told that they couldn't have children. I was certainly warned when I was diagnosed with my Crohn's disease that it would be most unlikely for me to fall pregnant. Didn't seem to matter to me. My body had a different idea. But more than half of the women, half of the drugs that we have don't have any research on them about how much gets into breast milk. And only 2% of them have good evidence from research. Obviously, the drug manufacturers can't undertake studies because nobody wants their precious baby exposed to a new drug when we don't know what the side effects are going to be. But we can collate information where maybe a mother has decided to continue, or she stops breastfeeding but provides milk samples. We can analyse those milk samples. But we need this information to be available for the wider population, not just kept hidden away anecdotally. But women with chronic diseases are 2.5 times more likely to not meet their breastfeeding goals simply because of their medication. All of us want to protect our babies, but the idea of exposing a baby to a drug through our breast milk is quite scary. But in fact, adverse drug reactions in breastfed infants are far less than we ever thought. So the biggest study of this was done by Phil Anderson, who actually set up LactMed, a free-to-access app that I'll talk about in a minute. And he looked at all of the possible individual reports of adverse events. And actually, there were no definite links. 53 possible, 47 probable, and most of them were in newborn babies, which is crazily the time when we give most drugs. If you think of it, in the first 48 hours after a baby is born, we're giving the mother painkillers, we might be giving her laxatives, we might be giving her antibiotics. Back when I started writing the drug fact sheets, they were giving everybody sleeping tablets to keep the mothers quiet overnight whilst the babies were taken to a nursery and formula fed. But the absolute incidence of adverse events is about 1 in 1 million. And it's not the same as pregnancy. If a baby is affected by a drug, it might become drowsy, it might have loose bowel motions, but it's not like in pregnancy and cases like thalidomide, we're not going to affect limbs. The only drugs which might possibly have long-term effects tend to be things like the social recreational drugs, particularly cannabis. By using pharmacokinetics, we can actually evaluate the risk of a drug passing through breast milk. Now, when I started writing my PhD thesis, I said to my tutor, the last thing I want to write about is pharmacokinetics. That's far too complicated. I was 40 odd starting my PhD. Can't do that. But now it's something I do on a day-to-day basis. And doing this, we can help to understand how much drug will get through, whether timing has any effect, um, whether what she's eaten will have any effect, but most importantly, things like the age of the baby and how much milk it's taken. And we need to balance the risk of the baby not continuing to breastfeed and the tiny amount of drug passing into breast milk. And there are a few drugs which it's not advisable to breastfeed with, but they're actually quite few. But women deserve that full information, not, no, you can't breastfeed with that drug. Because if you tell me I can't do something, I want to know why. I want to understand why you're taking my choice away from me. Now, this topic of pharmacokinetics could be a lecture in itself. So I've sent you a link here to a YouTube video that I've recorded, which explains in very simple detail how to look at the pharmacokinetic data. But we want things like drugs with poor oral bioavailability. So the drugs like gentamicin, insulin can't get into breast milk because they can't be absorbed orally. But that's also true of the new biological drugs which are taking over as very much more specific drugs for chronic diseases. We want drugs which are bound to the proteins in the maternal plasma, because the more that's bound in her plasma, the less can get through into her milk. And we want drugs that are come and gone as quickly as possible. The relative infant dose is something that's been around since the 1990s, but isn't in any of the standard textbooks like the BNF. It's a measure of the amount of drug that gets through relative to the amount that a baby could be given. And we want a level that is less than 10%. It's only in the specialised textbooks, and it needs to be interpreted along with everything else. But if you want to look into this more, feel free to contact me, and I'm happy to discuss this with you. The other thing we need to do is use drugs that might not be the newest, but ones that we do have data on. So, for instance, in ACE inhibitors, we'd use enalapril rather than ramipril because we have data on it and we use it indirectly in babies. But anything that's licensed for a child is going to be safe for a breastfeeding mother. So things like cloratidine, mebendazole, the threadworm treatment, are all compatible with breastfeeding. So this case study is about Tracy, who is exclusively breastfeeding her 3-month-old baby Suki. Now, it's unsurprisingly that this mum, Tracy, has Crohn's disease, because I have a Facebook page which is just for breastfeeding mums with inflammatory bowel disease. So I have a mass of times when people are being asking questions, and this is a common scenario. She needs a colonoscopy because she's having a bit of a flare since she gave birth. She stopped taking all of her medications when she was planning her pregnancy because she'd been symptom-free for some time, and this was her choice. It isn't necessary, it was just her choice. But she's told that she can't breastfeed during the bowel prep procedure and for 24 hours after the colonoscopy itself. Now, baby Suki has never had a bottle of formula, and Tracy is very aware that there is a possible link between formula feeding and IBD, and she is desperate not to expose her child to formula milk. But the appointment has come up as a cancellation, and she knows that she doesn't have a lot of time to discuss this, or to express and store some milk. So how is she going to cope? Now, the bowel prep. Sorry to talk about bowels and toilets this early on a morning. So she's given Moviprep. Now, what we need to do is to completely clear the gut of all of its contents. So effectively, we produce chronic diarrhea, which washes out the whole gut. We stop the mother, in this case, or the patient, eating any solid food, and we wash everything else out so that we can get a clear view of the gut lining. But Moviprep is a macrogol, and it sucks water into the bowel rather than being absorbed into her body. Why would we want a laxative absorbed into the body? We want it to act locally. So it's producing the watery, thinner bowel movement. So there is actually no risk whatsoever to the baby from having the drug. Practicalities of bowel prep is when you have to go instantly. So maybe she needs to plan ahead to make sure she has somebody to look after the baby, or she has a baby chair in the bathroom, or she has somewhere safe to put the baby while she has to go to the toilet. The risks of not breastfeeding during this period are that the mum will develop mastitis, because while she's so busy going to the toilet, she's not going to have a lot of energy to be expressing as frequently as her baby is feeding. And then she's going to end up with antibiotics, pain and discomfort. And also, baby Suki never had a bottle. And the technique of bottle feeding is very different to the technique of breastfeeding. The sedation that you get during a colonoscopy is generally midazolam. Midazolam is widely used for different procedures. It's highly plasma protein bound, so there's only 3% that can possibly get into milk. There's a ratio between the milk and the plasma, which is very low, so little in milk. Its half-life of 3 hours, and after 5 half-lives, the drug is all gone from the body. So why are we saying she can't breastfeed for 24 hours? Because every bit of it's gone in 15, and it's halving every 3 hours. And if you remember, I said the relevant infant dose, we wanted less than 10%, and this is 0.63. In all of the books, it used to say for babies under 4 months not to breastfeed for 4 hours. That actually came from a piece of research using midazolam as a hypnotic in the early stage after delivery. There's nothing whatsoever to do with anything else. But at 4 hours, they could detect none in breast milk. And that's where the 4 hours came from. One study in a completely different situation. Again, we have the risk. How is the mum going to sleep that night? Babies feed a lot overnight. Breast milk is not just about food. It's about comfort. It's about warmth. It's about security. She should be careful with co-sleeping that night because she may still be a little bit drowsy because she's had 3 days of anxiety during the bowel prep and the sedation. But there is no reason at all that she can't continue to breastfeed as normal throughout there. Her milk is not going to dry up, but she does need to keep drinking in order to be rehydrated, and there are certain liquids that you're allowed during the bowel prep that allow you to do that. But if Dad wants to meet them immediately outside of the colonoscopy room to feed, absolutely fine. What are the common myths about drugs in breast milk? The main thing is about those flipping leaflets that are in every box. And these are the manufacturer's instructions that are on which the license is based. And yes, they are needed and they cover everything and every possible side effect. But they almost invariably say either ask your professional, don't take if you're breastfeeding, because the manufacturers don't take responsibility because they didn't collect the data originally. It's not illegal to prescribe something that is outside of the manufacturer's specification. It just means you're taking professional responsibility. So what I would always do, either as a community pharmacist or a midwife, is make sure that I've documented the discussion I've had with the mother, exactly what I've said, and the sources I've used for that information. But telling a mother not to breastfeed, just in case, isn't always the best source of action. A lot of people get hold of the information about when the drug leaves the body, and they start saying to a mother, well, timing the drug will help you to minimize the amount that gets through to your baby. And for some reason, this seems to be most prevalent with antidepressants. So we already have an anxious, depressed mum. We tell her that the drug might get through to her baby, and she can't breastfeed for 6 hours after she's taken the drug. So she decides to take it at night, but then the SSRI makes her more wakeful, and then the baby wakes after 4 hours instead of 6 hours that it might have done before. I'd like to see a baby that actually sleeps for 6 hours. But you've got a more and more confused mum, adding to her anxiety. Please excuse my noisy dogs. Actually, after 5 half-lives, the drug is at a steady state. It's usually about 3 days. So anything that we're taking chronically isn't affected by timing. It doesn't matter if you take an SSRI and feed immediately afterwards, the amount in breast milk is minimal. What are the most frequently asked questions for me? It's usually analgesics, antibiotics, but about 20% are about drugs for mental health, anxiety, depression, bipolar, and sleep medication. But in the summer, it's hay fever remedies. At the moment, it's cough and cold remedies, but also procedures. And in each case, there are breastfeeding-friendly options for this. I'm sure all of you can identify with the capacity cup at the moment. Mental health is a continuum. It's a bit like a petrol gauge. Sometimes we're full, but sometimes we're empty, and sometimes we just have to acknowledge that today is a day we have to slow down and eke out the fuel a bit more. So no mother should be left in pain just because she's breastfeeding. The drug we want to avoid is codeine because there is a reported case in Canada of a baby who died after its mum had taken codeine and breastfed. But this was a newborn baby, and the mother kept saying this baby is incredibly drowsy, and everybody ignored her. At post-mortem, the baby was found to have incredibly high doses of codeine in its body because the mother was metabolizing and concentrating it in her milk. So if we need an opioid, oral morphine, dihydrocodeine, and oxycodone are all compatible with breastfeeding. Oxycodone is more likely to cause drowsiness in mum and baby than the others. And the same is the metabolism thing is also true for tramadol. Some people react much more strongly than others. But it's watch the baby. Don't watch the piece of paper that says. There are lots of places where you can freely access information. So LactMed, the app that I mentioned, developed by Phil Anderson, I have an app on my phone. Wherever I am, I can find out the information about the amount of drug that gets in, and it goes through all the studies, what happened to the babies, what happened to the milk supply. UK dialers are part of the UK Medicines Information Service, and they have some amazing information sheets which they are rapidly developing at the moment, and you can also phone them up to have a discussion about a particular mum's situation. Hale is the only resource that you would need to pay for. There is an online subscription, but it's also available as a book. The BFN fact sheets and breastfeeding medication fact sheets are all free to access, and those are the links online. But if you have any questions, I'm always happy to answer. So in conclusion, breastfeeding just isn't about milk transfer, it's about protecting the health of mother and baby. And it's looking at chronic diseases which are increasing in prevalence and may be linked to the way we feed babies. And the cost of treating chronic conditions is a major cost to the patient, the family, and the NHS. And we can't underestimate that. Chronic illness also leads to the use of climate resources to treat the symptoms of the patient. And formula manufacture actually has a significant cost to the planet. Another whole talk I could go into. So not supporting breastfeeding can have an incredibly high impact. As healthcare professionals, we can use evidence-based sources to check the safety of drugs, but we need to be sensitive to the needs of mothers. Let's listen to them. Let's empower them. But if you have a question from you or from a mother that you think I can help with, please feel free to contact me. If it matters to you, it matters to me. Thank you very much for listening, and I hope you have a wonderful day at the rest of your conference. Bye.